Today, my guest is Julia Wood, a dedicated occupational therapist who specializes in neurodegenerative diseases, particularly Parkinson's and related dementias. Julia's extensive experience, including her role as the Director of Professional and Community Education at the Lewy Body Dementia Association, equips her with knowledge and compassion for those affected by Lewy body. She's here to share her expertise and provide guidance on navigating the complexities of Lewy body dementia care. She's gonna help us unravel some of the mysteries around Lewy body, offer support, and share insights into managing this condition. In our conversation, we explore everything from what is Lewy body to the symptoms and behavioral changes associated with Lewy body, to practical strategies for communication, safety, and overall well-being. She shares with us the support systems available and how families can engage in advanced care planning. We are shedding light on the resilience and challenges faced by individuals and families navigating Lewy body dementia. This conversation is engaging. You will learn a ton and be supported by Julia's words of wisdom. Here is my interview with Julia Wood. Hi, Julia. It's so nice to see you again. We met briefly at the Mayo Clinic's, the conference on brain health and dementia, and we get to visit today. So thank you so much for being here.
Absolutely. Thank you so much for having me. It was such a wonderful opportunity to meet you and to get to talk to you again.
Thank you. I know, likewise. And that conference was so well done. It was so wonderful to meet all the people involved and how they support older adults, caregivers, just shining a light on that brain health. How was the conference for you?
It was fantastic. It was really great I got to touch on some topics that are really, I feel very important, in this realm, including coping with cognitive challenges. I did a session on the power of purpose, which was wonderful. And then also another one really talking about rehab professionals and the role they play. I got to really talk on some passion points and had a great attendance for all of them and felt like it was a really good session.
Oh, good, good. I know to be able to go into places and feel that our purpose, right? And
Yes.
educating, supporting people. So great. Thank you for doing that. I know I missed your session, but I will now next year. I'll be like, okay, where's Julia?
Absolutely.
Yes, yes.
Yeah, I'd love to have you.
That'd be wonderful. I know it was fun. I was able to see a few of my former podcast guests there, Lorenzo's house, which support younger
They're wonderful.
onset. They're wonderful, I know, and be a part of all of that. So it was great. Well, I'm happy you're here. I'd love to learn a little bit more about you before we kind of dive in, talking about Lewy body dementia. Tell us a little bit more about you, your story, and your work.
Oh, absolutely. So, my background is as an occupational therapist, and I had the privilege of specializing in Parkinson's disease and related movement disorders and dementias at the University of Pennsylvania's Parkinson's Disease and Movement Disorder Center at UPenn. And it was such a great experience because I just really had such a passion for learning about these conditions and working with them. And at the time that I was graduating OT school, I was actually told there was no role for occupational therapy in treating these conditions. It was really more physical therapy and speech language pathology. And I thought, I don't think so. And so I got this great job and became part of a wonderful interdisciplinary care team. My colleagues, Heather Cianci, she founded the center and she's a physical therapist. And Joellen Fox was a physical therapist there. And our speech language pathologist at the time was Meredith Pauley. And we truly had an interdisciplinary focus where we all worked together to really meet the needs, not only of the person with the movement disorder, but also caring for the care partner, extended family, sometimes in children. And I couldn't have asked for a better team. And so prior to that, my background was in wellness. My degree was in exercise science and wellness. And so I worked a lot on movement and ergonomics and safety with older adults. So I've kind of always had this focus on older adults and this love for working with older adults. So when the pandemic hit, I have a daughter with special needs at home, and I found that, clinical care doesn't really offer much flexibility that way. And so I had to leave clinical practice, and I was really devastated by that. And then I lucked out in getting a job at the Lewy Body Dementia Association. And so a huge part of my role as an occupational therapist is really education. I always wanted my patients and their families to really truly understand the condition, what the changes were, what that meant for them functionally and in their daily life, and how to cope with that. And so I feel really privileged now that I can take what I learned from my individual patients and from my care team and then help to really disseminate that out to a larger audience and to more people on a whole now at LBDA. And so it's one of those examples of, I think, one door closes and another opens.
Isn't that how?
And
Yeah.
yeah, I really love it. So it's been quite a journey, but I feel very fortunate to be where I am and doing the work that I do.
Oh, we're so happy you're here. We need that education piece and understanding. I think a lot of times when we don't know or have access to information, it affects our decision making, right? And we feel more alone in that. So being able to have you speak to all of that and support us is incredibly helpful. So super cute.
Absolutely. Happy to help.
Well, we're going to learn today, and I'm going to learn along with the rest of my audience. I know I have a great, baseline, but I think it's important. There's a lot of unknown around Lewy body dementia, and I'm excited for you to educate us on all the things. So, first of all, for people listening, what is Lewy body dementia, right? How does it differ from all the other dementias that we might be a little bit more familiar with?
Absolutely. So we like to say at LBDA that Lewy body dementia is likely the most common form of dementia that you've never heard about. And so for most people in our country, when they think of dementia, it's like automatically we think of Alzheimer's disease. And Lewy is very different. It's very complex. And it's actually much more like Parkinson's disease and akin to Parkinson's than it is to Lewy. So when we say Lewy body dementia, it actually equals two types of dementia. And so Parkinson's disease dementia is when someone's had a diagnosis of Parkinson's disease for some time. And typically that involves changes to movement, right? So people start to move more slowly. There's a shuffling gait, a stooped posture, sometimes a tremor, and even rigidity. And then over time, research suggests that around 50 to 80% of people with Parkinson's disease go on to develop dementia. And so that's when we're talking about PDD or Parkinson's disease dementia. In the case of dementia with Lewy bodies, the cognitive changes happen first or at the same time that the movement changes happen. So it's really one of our experts gave a talk recently, and she does this really cute slide that has a chicken and an egg under an umbrella. And so she says Lewy body dementia is that umbrella term. And then it's which came first, right? If the Parkinson's came first, then it's Parkinson's disease dementia. If the dementia comes first, it's dementia with Lewy bodies. And I find that's really confusing for families. Even when we do events related to Parkinson's disease dementia, people will come up and say, "Oh, I'm glad we're not in your camp. My husband still remembers all of our grandchildren's names. He just sees raccoons running up the wall." That's Lewy body dementia. So a big difference between Lewy and Alzheimer's is that Alzheimer's tends to have that amnestic presentation, those changes to memory, like we were talking about, where people can't remember possibly significant events or significant people in their life. Often people with Lewy body dementia, they may never have any of those cognitive changes that are amnestic. They may have some changes to their working memory, and so often related more to attention. So when we talk about working memory, it's things like walking into the kitchen and forgetting why you went there. So that's really a lot of times related to attending to a task. If you're not really paying attention when you put your keys in your pocket, you don't remember your keys are in your pocket. That's not an amnestic type of process. That's just really more attention. The other significant difference, too, is the changes often are in executive function. So that processing task, following sequence, following a recipe, maybe directions on a map. And that's another angle that Lewy has very specifically are these visuospatial changes. And so the hallucinations are part of it. That can be people can have very vivid, clear hallucinations of animals or small children, but they may have visuospatial changes that affect setting a glass on a table and recognizing how close to the edge it is or mapping their environment. And so there's this great slide that I have where one of our experts, Dr. Tanis Furman at the Mayo Clinic in Florida, did a study where she compared people with Lewy body dementia and people with Alzheimer's. And she had them do a whole host of neuropsychological tests, looking at their global dementia rating scale, looking at their attention, their visuospatial function, their memory. And what's fascinating is the global rating scale is pretty much the same, but that's where the similarities end. Once you start to look at attention and memory and visuospatial in those specific domains, they're literally often opposite. And so, Lewy Body Dementia Association was founded 20 years ago by a group of care partners who, as you can imagine, they had loved ones. They're going out trying to get support in like an Alzheimer's support group. And they're like, wait, what I'm going through is completely different, than what these individuals are going through. And so often families are left confused. Families don't understand. Cognitive fluctuations are one of the hallmarks of Lewy body dementia. So one minute, someone's loved one can seem really on and alert and attentive. And then a few minutes later, or the next day, or the next hour, they're completely zoned out. And so then even, if you have maybe a home health aide or a family member, they're like, well, he's faking it. He was fine a few minutes ago. But it's just almost like a roller coaster ride, the way their cognition is. So very, very different presentation.
So fascinating that we did a panel. There's a company called Viking Pure Solutions, and they have non-toxic where they have cleanliness in the environments. And one of the conversation pieces with different experts was a lot of times we do associate dementia with that memory loss, where a lot of people living with dementia don't have that component necessarily. That do you find that communities are looking at having environments more specific to dementias, whether it be FTD or Lewy body, because those needs and care are so varied.
I think that's starting to happen, but I think still, memory care is still what we think of with dementia care, and I think the needle's slowly moving. There's even some look at when you think about environments, right, for these individuals, even lighting, things like that. Shadows can really play a lot of tricks. So I think the environment is really important, and we need to start to think about in our dementia care settings, not just thinking about supporting memory, but thinking about a lot of things in the environment that can trigger a hallucination or delusion or even an illusion where the eyes just kind of play a trick. So, absolutely. I hope we see more of that.
I do too. I know. I'm hopeful. I'm hopeful. How many people are living with Lewy body?
The estimate is that there are about 1.4 million Americans living with Lewy body dementia. We suspect that it could be higher because the path to diagnosis is really, really challenging. On average, it can take around 6 to 8 clinicians sometimes to get an accurate diagnosis, and up to a year and a half of getting kind of jogged back and forth between different clinicians. And people with Lewy are typically diagnosed with something else first, usually Alzheimer's disease or Parkinson's disease. And then, we do still have, I think, some misunderstandings in the community that does it matter? Does it really matter if they have a correct diagnosis? Well, one of the drugs that they give often for agitation, haloperidol or Haldol, can literally be deadly for people with Lewy body dementia because it blocks dopamine. And so, it does really matter. It's important for people to get the correct diagnosis so that they can avoid medications that could be very dangerous. And actually, there are medications to treat a lot of the symptoms. They're often used off label, but there can be a lot of symptomatic management for people with Lewy body dementias.
Hey, that was one of my questions was how is it treated medically? We'll start there because and then I'll go back and ask them my other questions. What should we consider when we're looking at some of those medications or managing that?
Absolutely. So people with Lewy body dementias often have a lot of medication sensitivities.
Mm.
So it's really important for families to keep communication lines open with their healthcare team, and communicate changes that they note to medication. So if a dose has been increased or lowered, or maybe a new medication has been introduced, you really want to look for possible changes to behavior or side effects and discuss that with your care team. I think that, we still have a little bit of this little house on the prairie mentality, is what I call it with healthcare. We really see the doctor as the expert, and doctors are expert in so many things, but they really need that feedback and that communication from the family on what that medication does, on how the person responds. And I think sometimes people maybe feel a little pushy, or like maybe that's disrespectful, but that work with and that collaboration with the healthcare team is essential. And I also feel very strongly that people really need an interdisciplinary care team. Sometimes with Louis, the main symptom categories are changes to cognition, changes to movement, changes to sleep, changes to autonomic function, so blood pressure, constipation, urinary issues. And so we know that with all of these, and even neuropsychiatric symptoms, so that's the apathy, delusion, psychosis, hallucinations, depression, anxiety. So sometimes you may need a movement disorder specialist to address the movement changes. You may need a psychiatrist to look at the medications for all of the changes that way. Sometimes people need to see a sleep specialist. We have sometimes people need to see a gastroenterologist, or maybe a urologist. So, and even physical therapy, occupational therapy, speech language pathology. So it's really, I think, finding the right team and interacting with that team to help you manage those symptoms. Even counseling and social work, I should never overlook that, for the family to get strategies for coping.
Right, right. Yes. And so, as care partners, right, when we're with our loved one or people in our life, how do we, you name some of those symptoms, how do we effectively respond to some of those behavioral or psychological symptoms, the agitation or you mentioned the hallucinations? Are there are there things that we can do when we are spending time and trying to care effectively for people that we love?
Absolutely. So I think number one, I really encourage people, if you can find a good occupational therapist, even a good social worker, I think having someone to really help customize the strategies that work for you and your family is helpful. But my saying was always, idle hands are the devil's plaything. So as much as we can establish a sense of routine, of things that are enjoyable for the person, really having some supports in place for exercise groups, social groups, time with family, time with grandchildren. I think all of those things help to offset the behavior somewhat. And two, I think it's really getting support as a care partner for how you react to those changes. So, a dear friend of mine has Parkinson's disease dementia. And at one point, when he was beginning to have hallucinations and delusions, his care partner found it very distressing. I was like, I just don't want to hear about it. I don't want to talk about it. And I understand that. It can be really distressing and upsetting. But he saw how with our friend anyway, and this is not true for everyone for sure, was really able to talk with him and rationalize. A lot of times with Louis, something that can be very unique is they often have insight into their hallucinations. He'll say to me, I know it's not really there, but it seems like it is. And so then you can talk through it. Well, what do you think would help it maybe us not see that? Well, maybe if we turn up the lights, a little bit. Or, maybe it's at that time of day, if there's a lot of hallucinations going on, maybe that's a time to FaceTime with someone, or maybe do an activity. So I think it's really looking at, and keep in mind, all of this one day might work and the next day
Right.
completely might not. So I think so much of it too for care partners is really giving yourself
Mm.
grace that what works one day might not work the next. And that does not mean it's any failure on your part, that you're doing anything wrong. It's Louie. We always say blame Louie,
Yeah.
and
Oh, a
don't
great
blame yourself.
reminder.
Yeah, because I can't imagine. I have not been a care partner for someone with Louie. I've only treated people clinically, and then I have my friend. But I think that's so important is to, care partners try so hard, and they really think that if I just do the right thing, all these things are going to be better. And I think doing the right things means you're probably going to have more good times than bad, but those things are still going to happen and it's no one's fault. Yeah.
Yeah. And you highlight the communication piece. Have you found effective communication strategies that you've seen to be helpful and impactful?
Yeah, so a lot of times what I would do is really, depending on how agitated the person is, right? So if they're agitated, a lot of times that's not the time to try to rationalize. But if someone, they're kind of looking out of the corner of their eye and you can tell they're seeing something, they're reacting, I would just say, what's going on? What are we seeing right now? Oh, I see a little person over there. Well, do you think there's really a little person there? Or do we think maybe our brain's playing a trick on us? So a lot of times how I explain it to people with Lewy body dementia is there is a sensory motor connection that is impaired where sometimes people will think that they can't get out of a chair because their legs are too weak, right? Where actually they don't lean forward to stand up. And so if you or I tried to stand up from our chair right now without leaning forward, we couldn't get up either. So often, if they understand that trick that their brain is playing on them, where they're not aware of their movements, the same thing is happening in that hallucinatory state too. Their brain is playing a trick on them. And so then I think it helps to kind of normalize it and make it less scary. And I know my friend and I have a lot of conversations about, oh, what trick is Louie playing on you now? What's Louie? What signal is Louie giving you? I think humor sometimes can help. I mean, you have to always deliver that appropriately with your loved one. But, my friend, for example, he was very paranoid because often the delusions with Louis are very paranoid in nature. So they can be delusions of someone having an affair, infidelity, often called Othello syndrome. Sometimes someone might think their loved one's an imposter. And if you can start to kind of, communicate around those things, get some support around that can help. So my friend was really paranoid about the van outside. And I said, well, let's go take a look at the van. He thought this van was following him. And one of our neighbors has like a mobile sculpting business where he does, like the cryo sculpting for like, your abs or whatever. And I said, well, if this bus is following you around, clearly you must need some work done, which he got a real kick out of. And so now when he's over and sees the van, he goes, I guess I need some work on my abs. The van's outside. And so he remembers, right? Because he has that memory. And now that triggers that with him. Keep in mind, would that work with everyone's loved one out there? Probably not. You have to really take it on a case by case basis. But I find that a lot of times, the more you can talk about it, normalize it, really have a conversation, that helps tremendously.
Oh, I could see that. And the humor approach. I feel like we do forget that in those intense moments, but how
Yes.
important it is. It brings that levity. Yeah.
Yeah, and that a lot of times is where having a clinician in your back pocket to help can help because I imagine anyway, for a spouse or an adult child, it's not so funny in that moment. It's
Yeah.
really upsetting. And a lot of times that person that's removed from it a little bit can have that moment where they can take a little more levity to it and help to lighten that situation.
Yeah. Yes, completely. One of the questions that I had thought through when you were talking about, symptoms and how often it's misdiagnosed for families that are maybe new to this process, what is the pathway to diagnosis? Is there a way and I don't know, not best practice. I don't know if that's the right term, but how do we do that effectively so we can get that support we need?
Absolutely. So I think that a couple of tools that we have at the Lewy Body Dementia Association can be very helpful. We have a comprehensive symptom checklist that you can download off of our website that goes through the different families of symptoms. So then you can take that to your care provider and share that. Because if it's someone, say it's a primary care physician or even just a general neurologist, they may not ask those questions about Louis. And one thing I think that gets missed a lot is in our culture, we have a lot of stigma around psychiatric conditions and around mood disorders. And so I think often people don't ask those questions. Or maybe I think about myself, I don't know that I'd want to be like, I see raccoons running up the wall. You feel like this person's going to think there's something really wrong with me. So I think having that symptom checklist and where it lays it out and it's not this weird enigma thing, these are clear symptoms of this condition. Then it can open up a conversation with your provider about the different symptoms that they might not have even thought to ask. Um, the research suggests, unfortunately, that less than 10% of people are diagnosed by a primary care physician with Lewy, and they typically need a neurologist to diagnose it. So I think a lot of times, if you're maybe seeing your primary care physician, maybe you don't feel like you're getting the answers that you need, I would go to a neurologist, try to get a referral or go see a neurologist. And also, if you can, a movement disorder specialist neurologist or a cognitive neurologist can often do a little better job at teasing out those symptoms. Psychiatrists, too. I was just at the American Association of Geriatric Psychiatry meeting, and I have to admit my own ignorance. I didn't realize how much of a focus they have in dementia care and in understanding different types of dementia. So that opened my eyes to a whole other specialty. So I think it's really, if you feel like something isn't right, like you're getting this diagnosis and you're like, my neighbor across the street has Alzheimer's and this doesn't look like that. I think using the, educating yourself, using that comprehensive symptom checklist, trying to go a little deeper into specialties if you have the access to that in your community. And I know not everyone does. I think that can be really helpful. So it's a rocky path to diagnosis for sure. And I think that part of it too, and I even hate saying this in this podcast because I feel like I'm laying more burden on families, but I do think we really have to advocate. We have to go in and communicate and advocate. And I have to say, my daughter, it took us 14, 15 years to get a diagnosis of autism. And I had to advocate for years with this. So I think we all want to trust experts and that they can just do it. And we don't really have to keep, kind of beating on the door to get the right answer. But unfortunately, I think we do. I think there's more and more strains and demands on the healthcare system and on providers right now. And so I think more than ever, you have to kind of go in and really make them ask the questions and make them have the conversations that you need to have to try to get the correct diagnosis.
Yes, that's so true. There's a lot of care partners that are caring for loved ones in their home as well. And are there any safety considerations that we should be thinking through that are for those unique challenges? And I know that's kind of your sweet spot being an OT, and we'll talk about
Absolutely.
that too. So, how you support or how OT can support those living with that.
Absolutely. You saw the smile come on
Yeah.
immediately. So, a thing to know is that there's been some research that's looked at differences, even deeper with Lewy and Alzheimer's. They're much more likely to fall than people with Alzheimer's disease, and the time from the onset of the disease until they start to fall is much shorter. Also, nursing home placement a lot of times is quicker, and we know that the cost of care for those with Lewy body dementia is much higher than for those with Alzheimer's. So the falls risk, I think, is number one. I think you really want to have a good physical and occupational therapist to look at your home. You can a lot of times go through your area county on aging. Agency on Aging and get a home safety evaluation. So, looking at tripping hazards like rugs, widening pathways, because with the falls and Lewy, it's not just the movement symptoms. We know that with Parkinson's, the cognitive changes. So, for example, if you're walking in your home and you're carrying a cup of coffee, you're multitasking
Right.
because your brain is having to think about holding that cup of coffee, not spilling the cup of coffee, right? Keeping you right. as you're taking steps and moving. We don't think about that. For us, it just happens naturally, right? Now, let's add, say, you're in a restaurant and you've got a handbag on your shoulder, or you're carrying your coat and you're maybe carrying your water bottle. Now you've got even more things that your brain is thinking about. So we want to think about the cognitive aspects of that, how to kind of reduce the load on the brain when people are moving in their home and moving in the community. So, for example, if you're out walking around, you might not want to be carrying on a lot of conversations when you're walking down the street with somebody with Lewy, because they may be more likely to trip and not notice something in their environment. And then also the visuospatial function. So, widening pathways, having the home well lit, but not too bright to where you're getting a lot of glare, making sure, one thing that trips people up a lot of times are like glass top furniture. If you have glass top tables in your home with Louis, get rid of them, because it's like it's gone, right? There's just this big piece of glass. So people often will trip over them, fall into them. So yeah, I really encourage people to have that physical therapist to work with movement strategies, maybe gait devices, a lot of times a walker. And for example, too, please, 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 if possible, don't go out and just grab a cane because they're having trouble. You also have to coordinate that cane. So you've got to think of where the cane goes when you're stepping. So that's another cognitive load. So typically it's like a four-wheel rolling walker, like one of those that has the seat and the four wheels, that's more recommended. And then the occupational therapist too is going to look at the environment in the home. Do you maybe need a tub transfer bench, or bars around the toilet, things like that? So that's one thing for me. I almost feel like with my PT colleagues, it's like peanut butter and jelly. Like the
Yeah.
two of us have to be together, because I need their expertise for things like freezing. So where someone has akinesia when they try to walk, so they have a hard time getting their steps started, there's some great strategies that you can work on. But then we have to practice that strategy, not just maybe getting in and out of the car or in and out of the home, but going from the bed to the bathroom at night. We might need to light that pathway or have some motion sensor night lights. So there's so much you can do to help keep your loved one safe, but really get that support and that help too, so that you know exactly what to do and you don't buy unnecessary things.
Right. Right. Yes. Yes. The first part of my career, I was actually working on a transitional care unit. So worked very closely with PT, OT, and speech. And it really is the combination of all of that together that just can enhance the care. Yeah. There's a
Yeah.
company called Nobi Smart Lamps that I was able to meet and see at CES, which it was their part of um having a space there. And they are smart lamps that are placed in the home. And you're able to see, stick figures, so it keeps privacy. But as someone is like maybe getting up at night, it gradually senses that and raises the light so that you can see. But it also detects falls and various things like that. So I was like, oh my gosh, how cool. As you were talking, I was like, okay, lighting, the fall prevention, or understanding what is happening in those moments. Yeah, it just made me think of them. So,
Well, there's so many great tools out there right now. I mean, we've got so many great things. I've seen people take those, like, strip lights and make like a runway to the bathroom that then is motion censored, so when they get up, it's like they've got this runway to
yeah.
walk. I mean, people get so creative, and there's so many tools now that you can use. But then you also, my friend with Parkinson's disease dementia, his partner decided, oh, when they got their new home, like, we'll get an oven so that when he's completely wheelchair bound, he could still use the oven. And I had to explain to him, at the point that you're completely wheelchair bound with Parkinson's, you're not going to be using an oven. So it's not like that's more for someone with like a spinal cord injury or a stroke, something where they're still, able to function, but they need a little support. So that's why partnering with someone, you can waste a lot of money, because some of these things can be very expensive. And so, get the right people in place to support. And you guys too, I know that I really tout therapies a lot, but sometimes, just like doctors, you may have to kiss a lot of frogs to find a prince. Finding the therapist that matches for you and your family and for your needs. Don't feel bad being like, I don't think this is really working out. I think we need to find a different therapist, because it can take a little bit of time.
Ken, that's great advice to do that. It really is. And looking at those support systems, right, for care partners, how do we find them? And I know that your organization is one of those. Do you have any other tips or resources where you like to direct people for that support?
Absolutely. So LSVT Global, so it stands for Lee Silverman Voice Treatment. And this was a protocol, speech language pathology protocol that was developed some years ago for people with changes to their voice with Parkinson's. And then it turned into a partner program too called LSVT Big. And so they keep a registry of all the clinicians actually around the world who are certified. And so these clinicians, at least have some training and education and background in Parkinson's disease and these types of dementia. And so you can go on their website at lsvtglobal.com. They have a find a clinician tool where you can put in your zip code and put in a mile radius, whether it's 10 miles or 20 miles or 50 miles, whatever you're willing to do, and you can find someone. Another great resource can be the Parkinson's Foundation. If you call their helpline, which I can't remember the number off the top of my head, but if you go to the Parkinson's Foundation website, there's a program called the Allied Team Training Program, which I'm faculty for, and they keep a registry of all of the clinicians who have gone through that training and certification around the country. And these can be nurses, doctors, social workers. We've had some nutritionists. So it goes a little bit beyond even just your PTOT and speech. And I'm trying to think, I felt like I had another one and now it escapes me. I would say those are really the two big ones that can help you find someone in your area. And then also, too, a lot of times support groups can be a great resource in your area. So you may go to a local support group and there could be someone there that you learn about a home care agency or a therapy company or a doctor that you'd never heard of or didn't know about. And so that can be a great way. I find often those support groups, I learn more about other resources from the people in them than me trying to give support to the group. So I think getting into some type of a support group. And also, you can always call our Louie line at 1-800 539-9767, where you can email support at lbda.org. And we have licensed clinical social workers who man that phone. And you can sometimes you have to leave a message. We're not a 24-hour hotline, but they will do their best to try to find resources for you in your area to meet your needs.
What a great resource it is. And yeah, the personal recommendations I feel like go such a long way for people that are in
Yes.
it and find people that they enjoy working with. For planning, okay, so if we're thinking ahead of, we have our care partner, we're living with Lewy body, and we've got to think about what comes next. Do you have any thoughts or tips on what we should think about, right, as we're looking at that advanced care planning in the future?
Absolutely. Because that's something else that I didn't mention is that, we often get this question about stages. What are the stages of Lewy body dementia? Unfortunately, the presentation is so individual. Like we have a saying in clinical care that if you've seen one person with Lewy body dementia, you've seen one person with Lewy body dementia. Everyone's presentation is so unique. And so clinicians and researchers for years have been trying to figure out stages because we know that this would help bring some type of, at least planning and preparation for families. And they literally cannot figure it out. One person might live 3 to 5 years, and another person might live closer to 20. So there's not really any way to give you stages on that. But what I would say is, what I encourage people to do is think about long term. If when falls are starting to become a problem, psychiatric changes, things like that, look at your environment. Do you feel that you could stay there long term and be able to function? Don't wait until, because sometimes people are very like, well, we're going to wait as long as we can and stay here until we absolutely have to move. I think you're better to go ahead and figure out where you want to be, try to get maybe that home that has one level living, or set up your home to where you could be on one level if needed. Think about possible supports that you might need in place. But I think you want to start to plan pretty early. And I've seen a lot of people, in fact, even in my own family recently, someone waited. They actually moved to another home that still couldn't be a long-term solution. And then once he started having hallucinations and delusions, he'd had Parkinson's for some time, then they decided to put him into a facility and the wife didn't go. And it was one of those where you're like, oh no. I mean, I understand, but they couldn't even keep him in the care home. The psychosis was so bad. So you don't really want to wait and throw those things at someone. You want to let their normal be their normal as long as possible. And I know that can't always be, but I think start planning together kind of from diagnosis, like, is this our long-term plan? Could we stay here if we need to? What do we need to do to stay here long term? Are there maybe some modifications that you could make? Do you maybe need to have a plan in place for your adult children? We hear some of the best stories of them, having a schedule where, one person is from this time, another, the son-in-law is coming for the night shift. So I think thinking through that, talking as a family about what your resources are, what you're going to do if and when things become that way. And who knows, they may never, but I think really having that plan in place for long term is a really good idea from kind of from day one if possible.
I agree. Yeah, those are important questions to think through, right? To set us up for success. Yeah. You had talked
Absolutely.
about the research and, looking at the stages a little bit. Is there anything else happening in the landscape of research for Lewy body or ways that we can get involved in any advocacy things that are on the forefront?
Absolutely. So, some pretty exciting things that have come up recently. For the longest time, the only way to truly, the diagnosis of Lewy was clinical. You've got someone really looking at how you're moving, your, report of symptoms. And it was really a diagnosis based on your clinical presentation. Well, we're starting to have the emergence of some biomarkers where DAT scan, for example, can now scan a lot of times and see if there are issues with dopamine in the brain. Now, it's not necessarily going to tell you if you have Parkinson's disease dementia or dementia with Lewy bodies, but still, it can differentiate it from Alzheimer's, right? And from some other conditions. So that can be helpful. There's a skin biomarker that is not widely available yet, but is on the market where they can sense the presence of alpha synuclein, which is that protein that underlies these conditions. And so let you know kind of the realm, at least, that you're in. They can look at cerebrospinal fluid now, so do a lumbar puncture and test for that. So I think that a lot of this information, they used to have to wait really for an autopsy to know if someone truly had Lewy body dementia or not. And those days, I think we can tell now and get more information. We really encourage people, if you have an interest, to participate in clinical trials. There's some research going on right now. We have a couple of trials that are recruiting at LBDA for potentially disease modifying treatments that could possibly impact or slow the progression of the disease. So you can go onto our website at lbda.org, and we have a great resource called the Lewy Trial Tracker where you can sign up and there's no pressure, but you'll get notifications if there are studies coming up. In fact, there's a great trial coming up soon at Rush University called the Persevere trial. And it will be, I believe, available anywhere. And it's a care partner mentor program. So taking care partners who are maybe former care partners or have had 3 years of experience as a care partner and having them mentor someone who's new to care partnering. So they're not always drug trials, right? A lot of these trials are looking at quality of life, trying to maybe uncover stages. I believe Melissa Armstrong in Florida is working on a trial that way. So you can join our Lewy Trial Tracker and get updates of things that are coming out, what's new, what's hip, what's happening, and then ways you could get involved if you want, or you can just follow it as a bystander, and that's okay too.
Right. Such a good resource. And in addition to that, with the Lewy Body Dementia Association, what other programs are available? How do you support people? Tell us more about that organization and then, yeah, where we can connect with you there.
Oh, absolutely. So, our support line that I mentioned earlier, we have two licensed clinical social workers who are able to field your phone calls, get you connected with the resources that you want. And they also train a network of support group leaders throughout the country who host in person support groups or virtual support groups, sometimes both. And those are really our boots on the ground out in the community. Oftentimes, these people are former care partners or maybe family members of people who with Lewy who want to support other people now. So that's a great way to get involved and get support. And so you can always reach out to our support line and find out what's in your area or what could be available to you. For education, we have a host of resources. So we have about 2 live webinars a month that you are welcome to join us for on a variety of topics. I know this Thursday we have one on clinical trials and how you can participate. And often we involve people in the LBDA community and we interview them about maybe how they're participating in clinical trials or how they live with purpose. We get their insight as experts. And then we often have clinicians or doctors on really talking about those symptoms that can become tricky to manage. If you don't make the live event, because a lot of times I get tons of emails of, life happens, right? And they didn't make the live event. They're always available on our YouTube channel for viewing at any time, which is LBDA TV. So you can go to that site and watch our webinars from last year or from this year. Another great resource that we have is what's called the Lewy Learning Center. Everything's Lewy, if you notice, we're in Lewy land. So the Lewy Learning Center is our learning management system. And what it offers is video education where you can watch a video kind of in your own time, right? At your speed. We often have resources included with that, downloadable materials, handouts, things like that to help you get a little deeper understanding. As a director of education, I did some focus groups last year and really listened to what people were looking for. And what we heard loud and clear was I want kind of these little snack size bites. And then I want to be able to go deeper into the information if I want to with other resources. We have a great channel on our Mediflix. So if you're not familiar with Mediflix, it's Mediflix. And you can go onto that website and watch the film about Robin Williams and his battle with Lewy body dementia, which is called Spark, as well as some other short video vignettes about different symptoms. There's a great overview of the condition by Dr. Jory Fleischer, and all of that is available free and no charge. And then on our website, you can download a host of materials for you and your family, or if you're a clinician out there, you or someone with Lewy can reach out to us, and we will ship these materials to you at no cost within the United States. And then our research department, of course, has a lot of great updates with the Lewy Trial Tracker and with different things they'll post on our website or emails they'll send out about what's new and upcoming. And they also, if you're a clinician or a researcher out there, we have our Research Centers of Excellence program where we really help support these academic medical centers who want to provide support to their communities, want to do research, and want to really have excellence in care in Lewy. And if you really want to advocate and get involved, you can reach out to us to volunteer. We have people who host community fundraising events. Some people go out and do education in their community, or maybe even start your own support group in your community. So we encourage you, if you feel like this is something that would really empower you as helping others, please reach out to us and we'll find a way to put you to work, I promise.
So many wonderful options for us to be involved. I thank you so
Yeah,
much
thank
for
you.
shedding a light on this with us and your dedication and knowledge and compassion for those that are living with this dementia. So we appreciate it. And thank you. I learned so much. And now I know ways that we can all get involved and show up for people in our life. So thank you.
Absolutely. Thank you so much for the time. I appreciate it.
Be to have you. Thank you. Are you looking for more support and community? We sure are. That is why I'm so happy to highlight one of my favorite podcasts in the caregiving community, Confessions of a Reluctant Caregiver, hosted by my friends and sisters Natalie Elliott Handy and JJ Elliott Hill. They offer a unique blend of personal storytelling, expert advice, and candid conversations that shed light on the real-life challenges and triumphs that caregivers face. Tune in to Confessions of a Reluctant Caregiver wherever you enjoy your podcasts or explore more on their website at www.confessionsofareluctantcaregiver.com. Thank you for listening today. If you enjoyed our episode, please subscribe and give us 5 stars. In all honesty, we'd love to hear from you. Thank you so much for listening to our episode.